Alan, thank you, and that was a very nice introduction. And ladies and gentlemen, good morning. And it's my pleasure to share my experience with you this morning about how we use the open standards to tackle an interesting problem in our daily lives. And as an architect, you don't get invited to a problem. Somebody says, go solve this problem. They just give you a lot of stuff and they say, you go figure out what the rest is. So that's kind of what our story is here. And this is one of the things that it happened over the years with me, because this where we are today, it took 3 years to get here. So it's not an architecture that you do it in 2 weeks and hand it to somebody and go away and call it the day and you're done. So this is about a 3 years work, and we're not done yet. And when I was telling Alan yesterday, for me, the party has just begun, because from here on, I have no idea how to do what the rest we have to do. So that we have to learn as we go through. So let me talk to you about, there's 3 topics that I have 32 minutes. I have 35 on the slide. So I have 3 topics that I want to talk to you about. One is, what exactly is this capability? I'm going to drill down a little bit further for you. And secondly, I wanted to talk to you about how did we use architecture to actually develop this capability and how we went around. Now, at the end of the day, you're going to see this looks like a little bit of technology. But it's a little bit of technology. A huge piece of that is the people. If any of you ever worked in healthcare people do not like technology, especially the one we give them. They like MRI machines. They like X-ray machines. They love those ones. They do not like what we give them, because we don't speak the same language. And last part I wanted to give you with a 1-slide highlight is what exactly I took from TOGAF to do this. With that, let's start. So Alan said that this was the problem. In Ontario, they outlined a study and say our cost is going way up. We can't afford it. And in Canada particularly, is the health socialized medicine system is that the governments in Canada is much better shape than a lot of the other countries. Don't kid yourself. But at the same time, when the cost is going up, but you can't afford it. But thing that the Ontario Medical Association, they said, well, if we wanted to bend the healthcare cost curve, there are 4 or 5 areas we can focus on. They outlined 4 or 5 studies, 4 or 5 areas to focus on. But one of them is implementing leading practices. Because this is a healthcare, evidence-based practice is the standard. You don't just invent something and say, well, I'm going to do it this way now. No, that's a serious trouble. So they have to have an evidence. And so they said the leading practice, we need to start standardizing those practices. So that's where we focused on. And one of the areas that is, they look at it, interprofessional communication. Because healthcare is not about one person. There are a lot of people in healthcare. If you've ever been in an emergency room, you see those people tripping over each other all the time. You have no idea how anything gets done in there. But things do get done. So that's what we focus on. We said we will focus on leading practices. We'll start with interprofessional communication. And one of the biggest challenges that they have, especially in teaching hospitals, and teaching hospitals have 2 problems. One problem that is that patients are just sicker. They deal with the most complicated cases. And secondly, people change more often. Doctors and nurses and everybody else, every day there's new people around. So continuity in patient care is much more important. So the handoff becomes even that much more significant. So then what we did, we said, instead of building one holistic thing from beginning, what we will build, we'll start with the foundation, interprofessional communication. We'll build on top of it one process at a time. And at this point is that nobody knows what is the good practice. Everybody's practice is a good practice. So now we have to say, create a practice, standardize it, implement it, controlled and uncontrolled study, publish it, as long if it's published in New England Medical Journal, it's a standard. If it's not a standard in healthcare. People will not follow, because just because you said so doesn't necessarily make it so. So checklists and compliance, very simple things that we in other industries have taken for granted. Healthcare, those things don't exist. Not because they don't buy them into this thing, because the process by which we introduce those compliances, they hinder patient care. Minute some process hinder patient care, physicians and nurses and other allied workers will not use it. So if we give them a technology that doesn't work with them the way natural way of doing the work, they reject it. It's not that they're rejecting it, we just didn't give them something useful to work with. So it's not their fault, it's our fault. And one of the other things, the performance scorecard, one of the things that in healthcare, if you want to have a behavior modification, show me the evidence that what you asked me to do, it actually did something useful. Not 3 weeks from now, but today. You want behavior modification? Give some of the evidence that it did something. So that was the next thing in learning performance. So now next thing is going to do, if you're going to hold somebody accountable, then you also got to give them the tools to actually improve. Don't hold me accountable for something that then you prevent me, handcuff me from behind me and say, now go improve. Then I can't do a thing. Now you got to create a learning organization. And so as we went through, a lot of new processes got introduced. So it wasn't about just how you install a center line, or you install a catheter, or take care of a wound. It's a lot of other stuff that has to be taken care of. If you holistically look at it, that's the problem that we needed to solve. So if you look at it from all of this standpoint, so what we did is that we went through this journey. In April 2010, we implemented part of the solution. One of the things that we did is that interprofessional communication. And I call it a interrupt and uninterrupt messages. And it's a very important thing for them. Because if you think about it, is the main communication method in hospital today is paging. Nurse needs a doctor, she pages him. Guess what? He's not sitting in the office to return a phone call. So he's going to look at the page and say, yeah, it's beeping again. So he looks at that thing, okay, let me find a phone. So I get to the phone, I call her, in the meantime, nurse is going to take care of some other patient. No, she's not at the desk. He leaves a message and she calls them back. So they play that phone tag for at least a good hour. So now it's the interrupted messages that they're going. But a lot of the issues that they have to communicate don't need to be taken care of right away. Let me give you two simple scenarios. I got an 85-year-old patient who has not gone to the bathroom in 3 days, and if we don't do something about it soon, other complications are going to happen. So what the nurse has to do, she has to ask the doctor to place an order for suppository. Now, that doesn't have to be done in the next 15 minutes. But if it doesn't happen in the next 24 hours, something else is going to go wrong. So in our system, what it does is that it allows the nurse to place an order with the doctor and saying, in next 24 hours, please place an order for a suppository for this patient. It doesn't have to be interrupted. It could be queued in his message box. Alternatively, something else has happened. Patient's family is screaming at nurse, and now they're saying, we don't know what's going on with our family member. Now she has to find a doctor. Now, if she pages a doctor, he doesn't respond back in the next 20 minutes or 30 minutes. In the meantime, the patient's family is even getting more angry. So she takes the message and sends our message to the doctor and saying, patient's family here need to see you at ward such and such. Doctor knows everything about it. He gets a message and he looks back at his BlackBerry or iPhone, whatever he's got. BlackBerry's better. So she looks at it and he gets his messages. While he's walking over to the patient, he sees the history of the patient. What are the diagnoses? What has happened? What are the interprofessional communication has taken place? What are some of the key issues? So he walks up to the patient and the irate family and say he knows everything that he needs to tell the family. Just because a doctor walks up to you and tells you something with a certain amount of confidence, you feel better. Irate family have been diffused. So those are the interrupt and interrupt messages. So what we did in the results of this thing when we put it in is that 95% of the interrupted messages disappear because they could be queued. So now as a doctor, my BlackBerry doesn't buzz all the time. So when it does buzz, when my BlackBerry buzzes, it's important. And so this is the same thing, the other results in the amount of time it takes. On the average, nurses spend 3 hours a day trying to find who the doctor is for a patient. and then trying to find the phone number to call them. And that's the reality. And those studies have been documented. And handoff. At the end of the shift, you will see so many YouTube videos that it's a simple handoff in information loss is the patient's length of stay becomes from 5 days to 25 days. You didn't even go to diseases that you end up getting in the hospital. That's because simple handoff. So these are the things that we looked at. These are evidence we improved in April 2010. So then next thing that we went through into next generation. So from April 2010, we started working on next generation. One of the things that we learned very quickly in healthcare, social media is very acceptable format. They loved it. They love Facebook, they love a Dropbox, they love all of those things. So now we know something that they do like. And mobility, 99% of the workforce in healthcare is mobile. They do not have an office. And they will not have an office because as soon as they build a little office in a hospital, some epidemic happens, office is gone, the patient bed go in. And once the patient bed goes in, they never comes back out. So they don't have offices, they're mobile workforce. And we have to have a learning organization. At the same time, we create a learning organization, we have to create a culture, and we have to create a system that support it. And real-time evidence is that show me the evidence what you're asking me to do actually works. If you prove it to me, then I'll use it. So as a result, we've done a whole bunch of things, standardized a whole bunch of processes, and so that's what we did. So one of the things that I wanted to tell you is that by doing these simple things, we have a perfect storm right now in healthcare. We have clinicians who are accepting social media. We know that for a fact because the adoption rate. They just have, we have evidence for it that social media is accepted format in healthcare. And secondly, mobile technologies are becoming easier and better and faster. They have to use it. And third thing is that we have no money. All the things that, and whether it's Uncle Sam or any other government that you think about, in healthcare there is no money. Cost on healthcare is going up. Demand for healthcare is even going to go higher because as people get older. And somebody has to do something about it. So I think that by standardizing these processes, we actually have an opportunity to bend the healthcare cost curve. You don't reduce cost by reducing people's salaries. That's a left-wing thinking, doesn't really work too well. I froze somebody's salary, I can balance budget for the next 3 years. So guess what? The next 5th year when they come to negotiation, the cost is going to go way up. And they're going to turn us. Last 4 years, we have no raise. Okay, now we need 30% raise. What have we accomplished? Nothing. And so we have a chance. So